Imagine, imagine graduating at the absolute top of your medical class.
Right.
You secure a commercial lease for this brand new clinic. You buy all the state-of-the-art rehab equipment.
Which is incredibly expensive, by the way.
Oh, totally.
Yeah.
And you have this line of eager patients waiting at your door, only to be told by some faceless bureaucracy that legally and financially speaking, you basically do not exist.
Yeah. It's wild.
So today, we are looking at this invisible 6-month waiting room that every single new therapy provider is forced to sit in before they can actually, begin their career.
It really is one of the most glaring yet strangely under-discussed barriers in our entire healthcare system.
Yeah.
I mean, we are talking about a landscape where having the clinical skills to heal someone and actually being allowed to treat that person within an insurance network are just completely disconnected realities.
Exactly. So welcome to today's deep dive. If you are joining us, you are the kind of listener who, you look past the surface level. You want to understand the hidden mechanics, the underlying gears, and occasionally the tangled red tape that makes the world turn. And today's mission is exactly that.
We're getting into the weeds today.
We really are. We are unpacking the incredibly complex credentialing process that therapy providers, specifically physical therapists, occupational therapists, and speech-language pathologists, must navigate just to get to day one of patient care.
And to guide this exploration, we are analyzing this incredibly expensive credentialing checklist that was published by Prime Credential.
Right.
They are a specialized service that's entirely dedicated to navigating this exact administrative maze for new therapy providers.
What is a maze?
Oh, a total maze. And the source material lays out in just painstaking detail this massive mountain of verification that's required by government and private payers before a single dollar can change hands, or before a single treatment plan can even be officially authorized.
Okay, so let's start with the foundational layer. I think a layperson might assume that, credentialing is just a fancy administrative word for handing over your resume and maybe a copy of your diploma.
Right, like a job interview.
Exactly. Like you spent years in a rigorous academic program, you passed your exams, you have this embossed piece of paper from a university. Why does the healthcare system look at, say, a doctorate of physical therapy or a master's in speech-language pathology and essentially say, yeah, not good enough?
Well, what's fascinating here is that the degree is really just a measure of academic completion.
Okay.
It is not a measure of jurisdictional authority or ongoing clinical safety. Insurers and regulators, they view the credentialing process as an exhaustive safety check.
Because the liability is huge.
Enormous. Before any billing can legally happen, they demand rigorous verification. Because like you said, the liability is massive. The degree proves you got the education, sure, but it doesn't prove you are legally permitted to practice in a specific state. Nor does it prove you meet the universal baseline of skill that's required by national bodies.
Which brings us to the specific certifications mentioned in the Prime Credential Guide. They bring up SLPs, speech-language pathologists, needing something called ASHACCC on top of their state license.
Yes.
What is the actual mechanism behind that specific requirement?
So that is a perfect example of this multi-layered safety check we're talking about. CCC stands for the Certificate of Clinical Competence.
Okay.
And it's issued by the American Speech-Language Hearing Association. It's not just a piece of paper you apply for after graduation, like a club membership.
You actually have to earn it.
Exactly. Earning those Cs means a provider has completed a really highly regulated clinical fellowship under supervision, and they have passed a rigorous national board exam.
Wow.
Yeah, so when an insurance company sees that CCC, they aren't just taking the university's word for it. They have hard proof of a standardized, universally recognized baseline of clinical skill.
I look at this foundational step like, well, it's like acquiring a healthcare passport.
Oh, that's a good way to put it.
Right, like you wouldn't try to travel internationally and cross borders with just your birth certificate.
No, definitely not.
The birth certificate proves you were born, just like the degree proves you went to school.
Yeah.
But to actually move through the system, you need the official standardized passport. And in the medical world, that passport seems to be the NPI.
That's the trap, honestly. A degree and a state license just make you a qualified civilian.
A qualified civilian. I love that.
Yeah. To be a recognizable entity in the healthcare matrix, you need your National Provider Identifier, or NPI. It is a unique 10-digit number issued through a federal system called NPPES.
NPPES.
Right, which stands for the National Plan and Provider Enumeration System.
For you listening, think about every single medical bill or explanation of benefits, or even a prescription you have ever received.
Yeah, pull one up if you have it.
Seriously, if you look closely at the fine print, behind every single line item on that document, there is a unique 10-digit NPI. It ties that specific service on that specific day to a verified professional.
It is the absolute prerequisite for everything else.
Everything.
Literally everything. Without that 10-digit identifier, you are a ghost to insurance companies and government payers. And what makes the NPI so critical is that it's a persistent identifier.
Meaning it stays with you.
Exactly. The Prime Credential Guide notes that if you got an NPI during your clinical rotations as a student or maybe at a previous employer, you don't apply for a new one when you open your own clinic.
Oh, you just update it.
You simply update your practice details. It stays with you for your entire career, which honestly is the only thing preventing the system from collapsing under the weight of its own confusion.
Oh, I can imagine.
I mean, imagine if Blue Cross used one ID number for a physical therapist and Medicare used a different one.
And Aetna used a third.
Right. The fraud prevention and tracking mechanisms would completely shatter.
Okay, so given that our listeners know the chronic split between Medicare and Medicaid, what's staggering in this Prime Credential data isn't that the federal and state programs exist, it's the complete lack of data interoperability between them.
It's basically zero.
Right. We are talking about highly sophisticated databases. Yet, a newly minted therapist has to manually enroll in completely separate silos.
Yep.
Let's look at the federal side first. The source material points to something called PCOS.
Ah, PCOS, yes.
Yeah.
PCOS stands for the Provider Enrollment, Chain, and Ownership System. It is essentially the digital fortress for Medicare.
The digital fortress.
Truly. To bill Medicare, which is purely a federal program, therapy providers must submit an enrollment application known as Form CMS 855.
Sounds bureaucratic.
Oh, very. You submit it through this PCOS portal. The Centers for Medicare and Medicaid Services mandates this to verify literally everything from your educational background to whether you have any federal exclusions or penalties against you.
Like past fraud.
Exactly. And once submitted, that application is routed to a Medicare Administrative Contractor, or MMAC.
Amazing.
Right, which is actually a private healthcare insurer that's been awarded a geographic jurisdiction to process these specific federal enrollments.
Okay, so I understand federal Medicare needing its own gatekeeper, but so what does this all mean? If CAQH ProView is a centralized database for most insurance companies, why do therapists have to do entirely separate enrollments for Medicare and Medicaid? Doesn't federal clearance prove they are a safe, verified provider?
You would assume logical continuity, wouldn't you?
I mean, it makes sense.
It does make sense, but Medicaid is structured as a state-federal partnership, heavily administered by the individual states. They do not share a single front door with Medicare.
Wow.
Because each state controls its own Medicaid budget, its own network requirements, its own fraud prevention protocols. They demand localized control over the credentialing process.
So they just ignore the federal clearance?
Pretty much. The guide uses California as a prime example. If an occupational therapist in Los Angeles wants to treat Medicaid patients, which is known there as Medi-Cal Life, they cannot just check a box on their federal Medicare form.
Right.
They have to navigate an entirely different, completely isolated portal called PAVE.
Oh my gosh.
Yeah. 50 states mean 50 different sets of rules, portals, and document requirements.
It is wild that federal clearance doesn't automatically greenlight state clearance.
Yeah.
I mean, it forces these professionals to act as full-time administrative assistants.
It really does.
And hovering above all of these government silos is the private sector's attempt at centralization, which is CAQH ProView.
Right. CAQH, which stands for the Council for Affordable Quality Healthcare, is essentially a centralized repository. It's used by the vast majority of private insurance companies.
Right.
And the theory behind it is actually really sound.
How so?
Well, instead of a speech-language pathologist photocopying their state license and their DEA registration if they prescribe, and their malpractice insurance certificate, and their work history.
And mailing it to 20 different places.
Exactly. Instead of doing all that, they upload it all into their secure CAQH profile once. Then the insurers pull the data from that central hub.
Okay, the theory is sound, but here's where it gets really interesting. We live in a digital age, right?
Mm-hmm.
Everything in CAQH is digitized, verified, and centralized.
Yeah.
So why does the Prime Credential Guide explicitly warn that the process of getting in-network with private payers can take anywhere from 30 days up to 6 months or even longer?
That's a great question.
I mean, we're talking about verifying paperwork that is already sitting in a central database.
Yeah.
Let's talk about the why behind that 6-month delay.
If we connect this to the bigger picture, insurers really have no financial incentive to rush.
Oh, wow.
Yeah. That is the quiet reality of the credentialing bottleneck. Every single day a provider is kept out of network is a day the insurance company's not paying out top-tier, in-network reimbursement rates for their services.
Because they're saving money.
Exactly. It's framed as an administrative backlog. And to be fair, human beings at these companies do have to manually review applications to ensure compliance with specific network standards.
Sure, humans are slow.
But it is a backlog that heavily benefits the payer's bottom line.
That paints an incredibly bleak picture for a new clinic.
It's terrifying for them.
Think about the financial strain. You are a highly trained physical therapist. You have signed a lease. You are paying utilities. You have student loan payments kicking in.
Big student loans.
Massive. And the insurance company, moving at this glacial pace, essentially forces you to keep one arm tied behind your back for half a year. What are the real-world implications during that waiting period?
The immediate implication is restricted cash flow and a severely limited patient pool.
Right.
For government payers, the rules are ironclad. The Prime Credential Checklist makes it crystal clear. You cannot bill Medicare Part B at all until your PCOS enrollment is entirely approved.
So you just can't see them.
You are entirely locked out of treating a massive demographic of the population.
Can they at least see private insurance patients out of network while they wait?
They can, but that shifts the financial burden entirely onto the patient.
Oh, right.
Out-of-network reimbursement is significantly lower, and the patient's out-of-pocket deductibles are usually much higher.
Yeah, nobody wants to pay that.
Exactly. So for a brand new therapist trying to build trust and build a patient base in their community, telling a patient, hey, I can treat you, but it will cost you triple out of pocket because my paperwork is sitting on a desk at Blue Cross, is a terrible way to start a therapeutic relationship.
That's awful. And just when you think you've calculated the timeline and survived this 6-month, we hit the most bizarre phenomenon in the entire source material.
The closed panels?
Yes. The closed panel. It reminds me of the nightclub bouncer standing behind a velvet rope.
That's exactly what it is.
We have a well-documented national shortage of healthcare workers, yet an insurer can just look at a zip code and declare it full.
It is the ultimate paradox of the U.S. healthcare system. An insurance company utilizes these proprietary internal algorithms to determine what they call network adequacy.
Network adequacy.
Right. They might look at a specific geographic radius, see that they already have 15 in-network occupational therapists, and decide their network is closed. They simply stop accepting new providers, regardless of how highly credentialed or specialized the new applicant is.
But that internal algorithm completely ignores reality.
Completely.
Those 15 in-network occupational therapists might be completely booked. They might have a 4-month wait list of their own for new patients.
They usually do.
Meanwhile, you have a fully qualified, eager therapist literally across the street who is forbidden from joining the network. It just proves that network adequacy is based on an insurer's financial calculus, not actual patient demand.
Exactly. And when a provider hits that closed panel, they are forced onto wait lists.
Which is just more waiting.
Right. The Prime Credential Guide advises that in the meantime, the therapist has to scramble. They have to pivot and dedicate their time to applying for alternative, maybe less desirable insurance panels just to establish some kind of revenue stream.
Right.
It forces medical professionals to play a high-stakes game of bureaucratic musical chairs rather than, focusing on clinical outcomes.
Man. Okay, let's assume our hypothetical therapist survives the 6-month waiting room.
A miracle.
Right. They clear PCOS. They clear the state Medicaid portal. Their CAQH profile is fully loaded. They bypass the closed panels and finally get the official welcome letter from the major private insurers.
Celebration time?
You would think the finish line is crossed. But looking at the CMS regulations outlined in the guide, it seems like getting in-network is actually just trading a waiting room for a treadmill.
That is the perfect analogy. Getting credentialed is merely the entry fee. Maintaining it requires constant vigilance.
Yeah.
The administrative burden shifts from acquisition to maintenance, and the penalties for slipping off that treadmill are severe.
I was reading the CMS rules regarding updates, and it reminded me of having a notoriously strict landlord.
Oh, yeah.
You know, the type, if you change the locks or paint a wall without 30 days written notice, you face immediate eviction. According to the guide, a provider has exactly 30 days to report any major changes to Medicare.
The 30-day rule is unforgiving. If you move your practice to a larger space across town, if the legal ownership structure of your clinic changes, or even if you update your banking information.
Banking information, too.
Oh yeah, you have exactly 30 days to file those updates through PICOS. If you fail to meet that deadline, Medicare doesn't just send a polite warning letter, they can deactivate your billing privileges entirely.
Which means all of that federal paperwork you spent months securing is voided.
Worse than that.
Worse.
Much worse. If you continue treating Medicare patients and billing for services after that 30-day window has lapsed without an update, and CMS discovers the discrepancy during an audit,
Oh, no.
they can demand the recoupment of all funds paid to you during that unverified period.
You're kidding.
I'm not. You could owe the federal government tens of thousands of dollars simply because your administrative update was filed on day 35 instead of day 30.
That is a terrifyingly tight turnaround for someone whose primary job is supposed to be rehabilitating a stroke patient's speech or, helping an accident victim learn to walk again.
Right. Their focus is on the patient.
Exactly. If you are moving clinics, you are coordinating movers, transferring delicate medical equipment, notifying patients, ensuring continuity of care. And if you drop the administrative ball with the federal government for just a few weeks, your business is functionally crippled.
And the federal 30-day rule is just one component. You also have the relentless cycle of expiration dates.
More days.
State licenses must be renewed. Malpractice liability insurance policies must be renewed annually. And that centralized CAQH profile we discussed earlier, it requires an annual reattestation. Every single year, the provider must log back into the system, review every piece of uploaded data, and legally swear that the information is still perfectly accurate.
Yeah.
If any single one of these spinning plates drops, your network privileges can be suspended.
Which perfectly contextualizes why specialized services like Prime Credential exist in the first place.
Absolutely.
When I first looked at the source material, I wondered, why couldn't a smart, highly educated doctor or therapist just handle this themselves?
Right, they're smart people.
But looking at the sheer volume of redundant portals, the intentional delays, and these draconian maintenance rules, it becomes obvious. You aren't just hiring a service to fill out forms. You are hiring them to build a defensive wall around your clinic.
You are outsourcing the friction. Services like Prime Credential take a complex, error-prone, intentionally sluggish maze and turn it into a standard operating procedure.
An SOP.
Exactly. They leverage established relationships with payer representatives to push applications through the backlog. They monitor those frustrating closed network waitlists so the provider doesn't have to.
That's huge.
And most importantly, they track the myriad of expiration dates and 30-day reporting windows, ensuring that the provider never accidentally triggers a deactivation.
It makes complete economic and clinical sense. Your highest and best use as a medical professional is not sitting on hold with an insurance company's administrative contractor for 3 hours trying to update your practice address.
Exactly. The ultimate goal of navigating this system efficiently or hiring experts to navigate it for you is to remove the barrier between the healer and the patient.
It is an absolutely staggering journey we have unpacked today.
Right.
For you listening, think about the magnitude of what happens behind the scenes before you ever step foot into a therapy clinic.
It's a lot.
We followed our hypothetical provider from the moment they earned their degree and secured their state license and ASHE certifications.
Right.
We watched them obtain their 10-digit NPI, the essential healthcare passport.
Right.
We saw them wade through the disconnected, disjointed portals of federal PICOs for Medicare and state-run systems like PAVE for Medicaid. We uncovered the financial incentives behind the 6-month wait times in the private sector and the sheer absurdity of the closed panel bouncer keeping much-needed providers out of the network. And finally, we saw how getting approved just means stepping onto the endless treadmill of 30-day reporting rules and annual reattestations. It is a massive, invisible, and highly restrictive infrastructure.
Which leaves us with a fascinating unintended consequence to ponder. As these insurance networks make it increasingly difficult, delayed, and bureaucratic to get credentialed, we are actually seeing a massive industry-wide rise in therapists abandoning the insurance model entirely.
Really? Just walking away?
Yeah, to start cash-only or concierge practices, they are simply bypassing the 6-month wait and the 30-day treadmill altogether.
Wow.
So the question is, are these massive administrative moats, originally designed as safety checks, actually driving the very best, most sought-after therapists completely off the insurance grid?